Welcome back to the final explainer in our series on the bedside examination. This is it. We're putting all the pieces together. I'm going to show you how to synthesize everything we've covered into one single, really powerful protocol that can get you to a confident diagnosis in, believe it or not, just 5 minutes. All right, so let's dive right in. And to do that, we need to tackle the one big problem this whole system is designed to solve, and that's the risk of randomness in our examination. You know, a haphazard examination. We're just jumping from test to test. What does that get you? It gives you this pile of confusing, disconnected data, and that can lead to a misdiagnosis. But when you use a systematic sequence where one step just logically follows the next, you're transforming that random data into a coherent story. And that story is your diagnosis. It's really the difference between confusion and confidence. And honestly, it's absolutely fundamental to patient safety. So what exactly is this system? Well, let's lay out the framework. This is the high-yield, 5-minute examination that gets the job done. Okay, here it is. This is our clinical map, the 8-step protocol. It all starts with the patient's story, the targeted history. Then we move into a really precise assessment of eye movements to screen for any central signs. From there, we do our dynamic and positional tests to see if we can provoke those vestibular symptoms. Then we'll assess cerebellar function, and finally, we look at the big picture, gait and balance. You see how each step builds on the last? This is how we make sure nothing critical gets missed. You know, a protocol is only as good as its practical application, right? So let's actually put this framework to the test. We're going to look at two really common but critically different presentations of acute vertigo. So on the surface, we've got two patients who come in with acute vertigo. Case 1, they describe this brief, intense spinning that's triggered by movement, classic for BPPV. But then you've got case 2, who describes this continuous, unrelenting vertigo with some pretty severe instability. That's the hallmark of an acute vestibular syndrome. So right away, the history is pointing us in two totally different directions. Now, let's see how the physical exam gives us the definitive answer. And this really is the million-dollar question, isn't it? When you're faced with these two patients, how does our systematic protocol reliably and quickly tell the difference between a benign, totally treatable inner ear problem and a potentially devastating posterior fossa stroke? This is where it all counts. And boom, here it is. This is where the power of the protocol just becomes so obvious. The HINTS exam immediately shows us a critical split. For case 1, the findings are reassuring. Everything looks good. But in case 2, we see this triad of red flags: a normal head impulse test, direction-changing nystagmus, and a positive test of skew. That pattern right there is screaming central cause. Okay, let's just pause and focus on this key point for a second, because it's so important. A normal head impulse test, that's usually good news, right? But, and this is a big but, in the specific context of a patient with an acute vestibular syndrome, we're talking continuous vertigo for more than 24 hours. A normal test suddenly becomes a huge red flag. It's alarmingly normal. Why? Because it implies the peripheral vestibular nerve is actually working just fine. So the cause of that severe vertigo has to be central, and that means we have to think stroke. All right, so moving on in our sequence, the positional testing nails down our suspicion in case 1. We do the Dix-Hallpike, and we get a classic positive result. After a short delay, bam, there it is, that rotatory upbeating nystagmus that then tires itself out. It's absolutely textbook BPPV. And just as importantly, the cerebellar exam is totally normal, which helps us rule out any central mimic. Now, for case 2, as we'd expect, the Dix-Hallpike is negative. So, by integrating all these findings from our systematic exam, we can now arrive at a really rapid, confident diagnosis. And maybe most importantly, we know the exact right management plan for each patient. So here's the synthesis, the bottom line. The protocol has just perfectly separated these two cases. Case 1 is a mechanical inner ear problem, posterior canal BPPV, that we can treat right then and there at the bedside with an Epley maneuver. No imaging needed. Case 2, on the other hand, is a neurological emergency. Those HINTS positive findings are pointing straight to a central cause, very likely a stroke, and that requires an urgent MRI of the brain. Two totally different paths. And to make this protocol super easy to implement in your own practice, we've summarized it right here on this single checklist. Just think of it as a cognitive aid for your clinic. It's designed to make sure every single examination you do is systematic, reproducible, and complete, every single time. So, what are the crucial takeaways from all of this? Let's boil it down. First, this systematic exam is incredibly efficient. We're talking about achieving around 80% diagnostic confidence in just 5 minutes. That's huge. Second, it empowers you. It tells you when you don't need imaging, like in our BPV case. And third, and most importantly, it screams at you when imaging is absolutely vital to save brain tissue and potentially a patient's life. And that brings us to the end of this explainer, and actually to the end of our entire 5-part series on the bedside clinical examination. So let's just take a moment to reflect on the core message here, which is all about clinical synthesis. This one idea, I think, really encapsulates the immense value of your clinical skill. Look, technology is incredibly powerful, but it just cannot replace the real-time physiological insights you gain from a well-performed, structured bedside exam. It's truly your most powerful diagnostic tool. You know, over these 5 explainers, we've really gone on a journey. We moved from the foundational principles of nystagmus all the way through mastering the HINTS protocol and positional testing, and now finally landing here at clinical synthesis. Our real hope is that this has empowered you with a protocol you can use for confident, accurate diagnosis right at the bedside. If you want to continue your learning and get your hands on more clinician resources, please come visit our website at australiandizzinessclinics.com. And hey, if this series has helped you feel even a little more confident in your bedside examinations, please consider subscribing and leaving us a rating. It really does help other clinicians find this kind of resource. Thanks so much for watching.